Brooke Harvey is a program specialist at HIE, where she supports the development of the Pan-Canadian Health Data Content Framework that we heard about earlier, and she advances health data standards to enable seamless interoperability across the Canadian healthcare system. Brooke's work focuses on content standards, including co-leading the development of the social determinants of health data category, with the goal of improving healthcare quality, patient outcomes, and informed decision-making across the continuum of care. And Jennifer Lawson is also a program specialist at HIE. Jennifer supports the development of the Pan-Canadian Health Data Content Framework with a focus on terminology and value sets. Jennifer's work focuses broadly on social determinants of health data standards, setting directions for content development, consulting key sources and experts in support of adopting, adapting, and creating content to serve within the Canadian context. Jennifer's work at HIE was preceded with primary care research network involvement and literature applications for evidence-based medicine. So with that, I will pass over to Brooke and Jennifer to talk about the Pan-Canadian standards for health equity and social care. Over to you both.
Awesome, thank you. I'll just get the screen set up here.
So you're going first, Brooke?
Yes.
Okay, great.
Awesome. All good on the slides there, everyone can see?
Yep, that's perfect. Thanks, Brooke.
Great. All right, so hi everyone. Thanks for joining us today. Jen and I will introduce the Pan-Canadian Social Determinants of Health data standards and speak about why these matter for health equity and social care. We'll start with some foundational concepts by looking at health equity, social determinants of health, and social care to help ground the discussion. From there, we'll introduce the Pan-Canadian Health Data Content Framework and review the development process that supports this work. We'll also take a look at version 2 of the ESTO data category, followed by the roadmap and key sources that are helping to guide version 3 development. And finally, we'll close with a discussion of future directions for the ESTO data category. To start, I'd like to begin with a few key concepts that help frame the rest of this presentation. So before getting into the standards themselves, it's helpful to first ground our discussion in health equity, the social determinants of health, and social care, since these ideas provide context for why this work is important and what the standard is intended to support. Health inequities refer to unfair and avoidable differences in health and healthcare outcomes across populations, and achieving health equity is when everyone has a fair opportunity to reach their optimal health. HIE's approach to health equity recognizes that in Canada, differences across population groups remain significant for many healthcare indicators and are often persisting or worsening over time. In response, HIE's approach to health equity focuses on 3 connected areas of work. First, in developing and promoting sociodemographic data standards for consistent collection, analysis, and reporting. Second, integrating equity measurement into analysis and reporting to identify inequalities and opportunities for improvement. And third, developing methods and tools to help health systems measure and report health inequalities. And together, this approach reflects the idea that measurement matters because better data helps health systems identify gaps in care, inform meaningful action, and monitor progress toward improving care for all. So building on HIE's approach, the slide shows how health equity, ESTO, and social care are connected. The social determinants of health are the conditions that shape a person's health and well-being, such as income, housing, education, and food security, to name a few. And social care is the set of care activities and interventions that respond to those needs and strengths, including screening, referrals, navigation, and connection to community and social services. So in other words, the social determinants help explain why people experience different risks and barriers, while the social care aspect reflects how health and community systems respond to these risks. Health data standards are what make all of this measurable and comparable. By capturing information in a consistent and structured way, The standards allow organizations, settings, and jurisdictions to document social factors, needs, goals, strengths, and interventions in ways that can support whole person care, improve reporting, and strengthen planning and quality improvement. And most importantly, they help ensure that care teams have accurate, up-to-date information to better understand and respond to each person's circumstances. So looking ahead, we can also consider what becomes possible in a future state where ESTO data standards are adopted and implemented more consistently across the healthcare system. At the care level, standardized data can support whole person care by giving providers a clearer and more complete picture of the social factors that may be affecting a person's health. It can also improve coordination and referrals by making information easier to share and interpret across teams, organizations, and sectors. At the system level, these standards enable more comparable reporting and higher quality data, creating a stronger foundation for data linkage, trend analysis, and a better understanding of what is happening across populations and settings. Over time, this can strengthen program and policy planning, help assess whether interventions are making a meaningful difference, and support more efficient use of resources by reducing duplication, improving consistency, and helping systems target efforts where they're needed most. So what structure helps support this work from a standards perspective? HIE is supporting this through the Pan-Canadian Health Data Content Framework, which provides the foundation for organizing and sharing health data content in a consistent, structured, and coordinated way. So a little refresher here of what Shannon shared previously, an overview of the framework. And each block represents a standardized data category or a building block of health information that's organized across key domains like person, care team or healthcare provider, appointment or encounter, and organization. And the framework began with version 1 in 2024, expanded in version 2 for 2025, and version 3 that's shown in orange here in development with additional categories expected over time. So for today's discussion, our focus is on the social determinants of health, which is one of the foundational categories within our framework. So I've introduced the framework and where ESTO fits within it. The next question is how this content is developed. I'll walk through our development process that supports the creation and refinement of these standards. So we begin by drafting content based on identified priorities, key sources, known gaps, and insights from previous cycles, and then refine it through ongoing feedback and iteration. This work is highly collaborative, involving internal teams responsible for content standards, value sets, data architecture, as well as in partnership and consultation with various groups that I'll discuss shortly. Then the focus shifts from readiness for publication and release. And during this period, the content's finalized, aligned across relevant standards, and prepared for publication. Once published, the standard is promoted and shared more broadly to build awareness and support uptake, while outreach continues to gather feedback. And from there, the content moves into open review, which takes place for 60 days, typically from September to November. And this creates an important opportunity for broader public review and engagement by inviting feedback from health system partners, subject matter experts, implementers, and others who may use or be affected by the standard. Open review helps to validate the proposed content, identify gaps or concerns, and bring in perspectives from different settings and jurisdictions. After open review, we move into a longer phase of review, analysis, and planning internally. And during this time, feedback is assessed to determine what changes are needed, where there's strong support or differing views, and which issues should be prioritized for the next version. This helps turn broad input into a focused development plan. Overall, the development process is continuous, iterative, and structured around a yearly cycle, with new publications released each September for the framework. So like I said, this process is really collaborative and iterative. It's shaped by multiple perspectives that contribute to the development and refinement of the framework. Input comes from co-contributor and working groups that include patient partners, clinicians, researchers, policymakers, terminology specialists, and data architects. And feedback gathered through these channels is shared across the relevant internal teams so that the content can be reviewed from various perspectives. For this work specifically, the Social Determinants of Health Working Group plays an important role by bringing subject matter expertise to the development of the ESTO content within the framework. And through this process, we iterate the content and make changes to the data elements, value sets, and data models, ensuring alignment across teams and helping that the framework reflects a clinical reality, supports interoperability, and fits within real workflows. It also helps us better understand where data comes from, whether it's entered by providers or administrative staff, reported directly by patients, derived or machine generated, which are important considerations for developing standards that are both useful and feasible to implement. So as I mentioned previously, we engage in an annual open review cycle to gather broader feedback, validate the proposed content, and identify areas where the standard may need to be clarified, revised, or expanded. And here are a few examples from a previous open review period and how we responded. In one case, feedback on incarceration history raised some concerns that it may be inappropriate to ask in a healthcare context, particularly because of stigma, bias, and challenges related to interjurisdictional and institutional data sharing. In response, the data element was changed to legal history to broaden the scope beyond incarceration and reflect involvement with legal proceedings more generally, while still recognizing that this information can be important in some contexts, such as social prescribing. Another comment focused on household income, noting that people are often uncomfortable answering income questions and may leave them blank, making the data less useful in practice. And based on that feedback, the data element was removed because it can be difficult to collect reliably, difficult to interpret on its own, and is of limited utility in assessing financial stability without additional context. And a third example here suggested including place of residence, such as whether a person lives on or off reserve, and whether they live in an urban, rural, or remote setting. And this was identified as for future consideration, and more broadly, it reflects a set of comments related to First Nations, Inuit, and Métis determinants of health. And from that feedback, a new stream of work has been initiated to develop a data content standard for First Nations, Inuit, Métis determinants of health through a working group led by and comprised of First Nations, Inuit, and Métis people. Okay, so I'd like to turn to the current social determinants of health content in version 2. Here's an overview of the elements that were included in version 2 of the ESTO data category. In the person category, the focus is on sociodemographic characteristics that are more static and some of which can be used as equity stratifiers. And in the ESTO category, the content is oriented towards the social and structural factors that affect health and well-being, including areas such as education, housing, social supports, and legal history, as well as access-related elements like food, transportation, and childcare. And together, these categories create a more complete picture by combining person-level sociodemographic information with data about the social risks and needs that may shape health outcomes and care experiences. So here's an example of what the data content standard looks like in published format. This is from our version 2. For each data element, the publication includes the data element name, definition, along with its associated maturity level and the related terminology foundation, recommended value set examples, and the maturity of those components as well. So the data element is the specific unit of information being captured. The Terminology Foundation represents the broad set of standardized concepts that support exchange, and the value set provides the defined list of permissible values recommended for use. And including the maturity levels across these components helps show how developed and implementation ready each component is, while also supporting transparency as the standard continues to evolve and be refined across future releases. So diving a little deeper, here's a few specific examples of ESTO data elements from version 2, drawing from the screening and assessment content. So these elements were listed with proposed data element maturity, while the associated terminology foundation and value sets, including the fixed LOINC codes, were identified as in development. For housing stability and financial stability, the value set reflects concepts we are seeing in the Australian Core Data for Interoperability, or the AUCDI, while access to food was presented more in line with content of the SPARC survey. So I've made some reference here to SPARC, AUCDI, and LOINC, all of which are important guiding sources in this work, and Jen will go into more depth on these and how other sources are informing version 3 development. And with that, I will hand it over to Jen to walk us through the roadmap and key sources guiding version 3.
Thank you, Brooke. I'm just going to do a shift of slides. That did not work, I imagine.
Nope, you're on your email right now.
Okay. Okay.
So we see the full PowerPoint right now. Middle.
Okay, and I'm just going to switch display settings.
Yep.
Okay. Even though it worked in trial.
Swap. Yeah, got to swap. Yeah.
Okay, thanks everyone. Okay. So I am going to take over the presentation from here. Thank you, Brooke, for sharing that background and the foundational information, including what has been published in V2. This portion of the presentation will demonstrate how we have applied the data standard process to create content for the ESTO domain in version 2 and 3 of the data content standard, and where our roadmap is going to take us in the future. So just to recap, in version 2 of the data content standard released last September, we had 2 clusters of data elements, one within the person information category, defining several sociodemographic attributes. In another cluster, there were data elements that related to screening and assessment of social risk and social needs. In version 3, sociodemographic attributes will remain in the person category, and we have further developed this screening and assessment category in context of future work toward defining a composite of data categories that we refer to as the social arc. These categories include confirmatory identification of social risk and social needs and protective factors, person goals that define their desired outcomes, and finally, social interventions which describe the action and support that can be provided to patients and to enact social care plans that treats the whole person. This framing for social determinants of health data standards is guided by several sources as outlined here. This slide includes links to describe those organizations, their products, and I'll be touching on several in the next slides. So to begin, the Upstream Lab at the University of Toronto has produced what is known as the SPARC tool. In long form, it's called the Screening for Poverty and Related Social Determinants to Improve Knowledge of and Access to Resources. And this survey has undergone testing to prove its validity and is currently being piloted across several Canadian provinces. This slide shows how they have a section of questions related to demographics and another section on social needs. Questions and response formats vary across the Spark survey. Some domains ask a singular question, and others, as shown here for the housing-related domain, include multiple questions. Some questions encourage a single response, and some allow for multiple responses or even narrative text, but all include options for do not know and prefer not to answer. Some responses include multiple concepts, while others are simply a yes or no. Coding survey questions and responses with a terminology like SNOMED CT that requires concepts to have a narrowed meaning has proven challenging, and yet the LOIC coding system provides a means of preserving the survey content, and I will demonstrate that in some upcoming slides. Another important guiding source has been the Gravity project. Gravity was launched in 2019 and works toward developing social determinants of data standards. They have a robust standards development process that we would like to mirror that involves reaching consensus across multiple stakeholders, achieving standards ready for implementation and practice within social care. They have guiding principles that align with HIEs, including a primary focus on improving person-level health outcomes and preventing, reducing, and remediating harm and ensuring patient autonomy. Gravity's conceptual framework demonstrates the importance of a social care workflow, beginning with screening and assessment, through to identifying social needs and problems, marked in this slide as diagnosis, and establishing patient goals, and then finally enacting interventions. All of their collaborative work is published to their Confluence page, and I've offered a link to that page on this slide. 3 interconnecting work streams guide Gravity's work. The terminology work ensures concept coverage for Gravity's ESTO domains from coding systems like SNOMED CT, LOINC, and ICD-10. Their technical domain translates their data elements and value sets to HL7 FHIR specification, which is balloted and published with regular new releases. A link to the latest FHIR implementation guide is in the top right corner of this slide, and you can access that at your will. You can see too that the coded value sets are a key central component to both of these work streams. And finally, their implementation work conducts tests, pilots, and helps support adoption of Gravity-related standards overall. Also of note, their work is vendor agnostic, which also follows HIE's stance on data standard development. As mentioned, Gravity has done a tremendous amount of terminology work, identifying gaps and creating new concepts and value sets. Their terminology work is published on the Value Set Authority Center, hosted by the National Library of Medicine. And the broad scope of Gravity ESTO domains are presented on the right-hand side of this slide with a note that for those that are being newly developed in that red square. So work is ongoing and continuous, as Shannon had alluded to, is the game of data standards development. Switching gears now for a moment, another important influence on our ESTO development work has been the Australian Core Data for Interoperability, which can be likened to our Canadian Core Data for Interoperability that Shannon touched on earlier. This document serves as the standard reference for clinical data design, ensuring interoperability between both existing and future health care systems. In Canada, we can relate to this challenge of developing data standards that bridge both legacy and future forward systems. And the AUCDI's last release was in June 2025, so we are likely to expect its third release this coming June. Specific domains within the AUCDI has helped guide HIE's data standard development. For example, the food and nutrition summary shown here provides a conceptual model, which is in its early stages of development. So for now includes data elements of an overview, food security status, and date last updated. The information model section includes descriptions, use cases, and a current status for each. In other segments of the standard, it specifies its scope and use and misuse, as well as references for their work, which here you can see includes Open EHR, which is an organization devoted to health information modeling, the Gravity Project, and the work of government committees and guidance from surveys. Drilling a little further in, they offer details on the model data elements, including the one I'm showing here of food security status. Here you can see that they've designated it as a codable concept with recommendation of SNOMED CT AU for its Australian edition, that is, for its value set. The concept examples forms a gradient that you can see of food secure through to food insecurity. It is possible to adopt this value set for our Canadian standard, which I'll discuss in a moment. Further, they frame this data element as having utility in a patient's longitudinal health record for monitoring a patient's status over time, supporting continuity of care, and reduce reassessments. We've heard from our co-contributors of the ESTO that ESTO data elements that provide a simple status marker creates more opportunities to practice social care, shedding light on what interventions for diabetes, for example, are more likely to bring about positive outcomes. As well, status data elements serve to signal the need for further conversations with the patient to confirm and to prioritize social risks and needs, and also encourage patient goal setting and agreed upon interventions related to reducing risks and harms. In other words, triggering the social arc workflow. Data element definitions are key components of data standards development. And these anchor understanding of both the scope and purpose of the data element and for defining its value set. As part of our environmental scan work, we reference both academic and white paper literature. And as shown here, the Integrated Food Security Phase Classification, known as IPC, has identified 4 pillars of food security, including availability, access, utilization, and stability. Researchers led by CLAP suggest 2 more concepts, and these are agency and sustainability. The AUCDI definition reads as assessment about consistent and reliable access by the individual or their family to sufficient, affordable, nutritious, and culturally suitable and safe food obtained in socially acceptable ways. So, taken together, we have formed a draft composite definition for food security status that maps these concepts and aligns with other definitions within our data content standard. We also make use of national data survey guidance, such as the Canadian Household Food Security Survey module. In this instrument, we found a parallel gradient type of category of food secure through to severe food insecurity. The survey provides guidance that if responses are moderate or severe, that a finding of food insecure be identified. This has bearing on the next steps of the social care workflow, where clinicians and community service practitioners take screening and assessment data to form ESTO diagnoses or identified social needs, to form a patient's holistic care and action interventions that reduce their social risk. Okay, so in this last topic of our presentation, I am going to hone in on the role of terminologies and classification systems that support ESTO data standards. As mentioned in the review of AUCDI's food security status data element, there is opportunity to adopt their value set guidance within our Canadian data content standard. We are currently determining their fit for purpose in the Canadian context, in fact. This slide shows the nutritional finding branch for SNOMED CT AU on the left and the Canadian edition on the right. We can see where Australian-specific food insecure concepts were created as child concepts of food insecurity, noted with their Australian flag. And on the right, the gap that would need to be filled within the SNOMED CT Canadian version. To do this work, we partner with our Canadian Health InfoWay partners, folks, to either propose promotion of these concepts to the international edition of SNOMED CT, which would make them available across all country-specific editions, including ours. And another option is to make a request for these concepts to be added specifically to the Canadian version, where our flag would then mark this new added content. So turning now to another international coding system, which is LOINC. LOINC stands for the Logical Observation Identifiers, Names, and Codes. It's most notably known for coding laboratory values. However, the Gravity Project and LOINC have teamed up to encode multiple ESTO survey instruments as standardized LOINC panels. The link to the publication on the left describes this formal collaboration, which is to advance interoperability or interoperable representation of health-related social data needs. Social needs data, sorry. The slide also shows the LOINC panel coding that designates a code to identify the survey, in this case, a Hunger Watch vital sign survey, a unique code for each of its questions, and one for the answer list. And as mentioned earlier, we have an opportunity to promote other validated Canadian surveys as LOINC panels as well. And here I'll just say, I did notice, Linda, in your next session with students following these talks that you're going to be looking at Prepare, and Prepare indeed is wholly coded with LOINC in the same fashion. Another use of LOINC occurs with the use of fixed codes that help anchor data elements, especially as they are translated to observation profiles within HL7 FHIR. This slide shows some of the work to date on finding an appropriate LOINC code to represent some of the ESTO data elements. For food security status, the current available codes are tied to a US food security survey, and something, the CUBS is the Comprehensive Universal Behavior Health Screen. In the next row, housing stability status code options lack the aspect of stability. And for the financial security status, no codes were found. So for these cases, we can again work with our InfoWay partners to request codes that are neutrally named and fit the Canadian context and better reflect the data element itself. There's also certain classifications that support data standards. The Canadian version of ICD-10 includes the chapters of Z55 to 59. A more detailed view of Z59 shown here is related to representation of problems related to housing and economics circumstances. And of note, professional coders have been given direction for applying Z59 decimal 0.0 to indicate homelessness when unsheltered, emergency sheltered, or provisionally accommodated circumstances are detected in a given patient. And for these reasons, the Z code beyond others likely has greater frequency of use in Canadian hospital data. The last topic on our presentation ties together the guidance we've explored toward informing how we are presenting ESTO data standards in version 3 and future developments. So with food security as our example, this slide depicts the directions we'd like to go to define data standards for the social care arc, including screening and assessment, identified social need, goals of the person, and interventions. And so the top row here of the table indicates the code system that is applicable to each segment. In screening and assessment, a LOINC fixed code can be used for anchoring the data element and for coding validated surveys. SNOMED CT would most likely be applied for the value sets. And as mentioned, the potential adoption of the AUCDI value set shown here in the value set examples is in current discussion. Moving on to the identified social needs, SNOMED CTCA value sets could define more specific types of food insecurity, for example, related to difficulty affording food or having limited access to culturally sensitive or appropriate food. ICD-10-CA could be mapped to these codes to use for use cases that require data aggregation. Food security patient goals could be captured with SNOMED CT again, and for concepts, and these for concepts that want improvement to reliable access to food or establishing a place for food preparation. And finally, interventions can be coded with SNOMED CTCA and CCI to name procedures related to assistance, referrals, coordination, and counseling, and others. All right, lastly, I will state that there are ways to become involved in HIE's data standard development. Brooke and I facilitate, for instance, the Open ESTO working group, currently hosted on the Info Central platform, and I've added a link to check that out. As referenced, we are developing content currently for the Pan-Canadian Health Data Content Framework V3, released this September. This is followed by an open review period that runs October to November. So look for announcements for ways that you can provide your feedback. And beyond that, please reach out to the Connected Care at kihie.ca inbox for all other data standard questions and comments related to HIE's published products and future data standards work. Thank you. And we are happy to take questions on, at this point, this presentation and any of the others provided by my HIE colleagues.
Thank you so much. That was such a great segue into the activity that the students will be doing later, providing such a comprehensive overview of the state of play with social determinants of health with both the CACDI, the toolkits, and the terminology aspects. So really appreciate that. Brooke and Jennifer, thank you so much.